Well, just as we looked at the two drug classes
that we use to help people breathe who have COPD, these are the drug classes we use to help people who have asthma. We use the rescue inhaler, you know it as albuterol. The inhaled steroids. Remember that the inhaled steroids are drugs like fluticasone, mometasone. The inhaled steroids or oral steroids, remember, end in what suffix? Own, like prednisone, methylprednisolone. Yeah, so when it ends in own, you ought to be thinking of steroid. Now, there's one exception to the own rule about steroids for asthma. The exception is budesonide. And the reason you need to remember that as an exception is because it is the only inhaled steroid that can be nebulized. It's the only inhaled steroid that you can nebulize. So in an older adult or a young child, when you have to nebulize a steroid, it's going to have to be budesonide. And when you look at the third class of meds that we use to manage patients who have asthma, the third class involves a steroid plus a LABA. Now look at the names of these drugs, and I know you know all of them. Advair, Brio, Symbicort, Dulera, those are the ones that are on the market right now. Don't memorize what steroid and what LABA is in them. Just know that in combo agents for an asthma patient, a combo in an asthma patient typically means a steroid and a LABA. Y'all got it? All right. This is a tough section. It just is. There's a lot of drugs, a lot of diseases. Two more important points about asthma. They both are points about safety in patients. The first one is every asthma patient's got to have a SABA. Got to have a rescue med. If you bronchoconstrict and you can't breathe, they better have the access to this. And the second safety issue is you never, ever, ever use a LABA in an asthma patient unless you also have a steroid on board. You never use a lone LABA in a patient. For example, you would never put an asthma patient on just salmeterol. If you do, you better have a steroid on board as well. How come you don't have a lone LABA? Let me give you a clue. It's bad for business. Yeah, they die. Here's what happens. They bronchoconstrict and they can't open up. They got to be in the right place at the right time or it's going to be a sad day. All right, so that's it. Let me ask you a question. Does a patient with asthma need a pneumococcal vaccine? Yeah. So they need that. They need a flu shot. And look at the last bullet because it's what Amelie calls the fountain of youth. It's exercise, right? And so you're going to hear me encourage you at least 3 more times before we leave how important exercise is, even if you start with 5 minutes a day, all right? It's a fountain of youth for sure. Lots of patient education with asthma, right? Here it is. And we've arrived at this section. Take a really big, deep breath, and let's check your knowledge. So I have a little game for you. And the game is called Name That Differential Diagnosis. You ready? Name that differential diagnosis. So here's your patient. I'm going to give you 4 of them. Your first patient is a 65-year-old smoker. He's coughed for the past 4 days. They have fever, and they're short of breath. When you build your differential diagnosis, I know you're going to include pneumonia. Circle it. Since we don't know how high his fever is, I think you have to circle acute bronchitis. He's a smoker. It could be a COPD exacerbation. I think you got to circle that one. But neither pertussis nor TB usually presents like this. They don't usually present with fever, and they don't usually present with shortness of breath. So I would circle them all except pertussis and TB. Next patient. A 60-year-old smoker coughed for the past 14 days without improvement. Denies fever and denies shortness of breath. They just coughing. What's in your differential? GERD, circle it. Lung cancer. Can you rule it out? No. Circle it. What about TB? Could be. Circle it. What about a COPD exacerbation? Oh, yeah. New onset asthma. When's the last time you saw new onset asthma in a 60-year-old? Okay, case made. How about a pulmonary embolism? I don't know, for 14 days, no shortness of breath. I don't know about it. And the last one says heart failure. 14-day cough, no shortness of breath. It's unlikely. I think I'd circle everything except new onset asthma, a PE, and heart failure. I'd circle the others. Now, got it? Here's your next patient. It's a 24-year-old first grade teacher, poor thing, who's coughed for the past 3 days, denies fever, and takes an oral contraceptive pill. She's on an OCP, so she's coughing. Last 3 days, no fever. Could it be TB? Well, a first grade classroom is a cesspool, so I think you need to circle TB. I certainly think you need to circle pertussis. What about a PE, pulmonary embolism? What might have increased the likelihood of that? She's on an oral contraceptive, sure. New onset asthma. In a 24-year-old, it's possible, but it's not real likely. Would I circle it? I probably wouldn't. Could it be an asthma exacerbation? Yeah. Could it be GERD? Yeah. If you're a first grade teacher, you probably just want to have a Valium lick in your classroom, right? And then look at your last patient. A homeless 50-year-old with a cough for the past 3 days. He's got hepatitis C. He's got fever. I don't know if I'm running fever because he's homeless. He doesn't smoke. He does have malaise, fatigue, and shortness of breath with exertion. He's your guy. When I'm looking at differentials, you must circle TB. Why? It's prevalent in a homeless population. He could have acute bronchitis. Circle it. Could he have pneumonia? He could. Could he have a PE? What risk factors for a PE would he have? And I don't think he does. Most homeless people walk, they move. So I'm not kind of thinking, what about heart failure? Does he have any precipitants? Okay, he's 50 years old. He probably has a lot of mileage on him. I wouldn't initially circle heart failure unless there was something else in the stem of the question that gave it to me. I would circle TB, acute bronchitis, and pneumonia. Those are the most likely, right? And that's what I asked you about, likely differentials. Take a look. A patient with an asthma exacerbation and wheezing is in your office this morning. When are you most likely to hear wheezing? Well, what produces wheezing? Look, it's a narrowed airway. So let me ask you this question. Are your airways more likely to be narrowed when you inhale or when you exhale? When you exhale. Now, when during exhalation or expiration? End expiration is the time you hear them if they're there. Sometimes in regular expiration you hear it, but the airways are more likely to be narrowed when you exhale. So that's when you're most likely to hear it. Circle number 3, during expiration, most likely. And then I think this is pretty close to your last one. Which of the following are indications for a chest x-ray? Select all that apply. Well, cough with fever, for sure. What are you looking for? Pneumonia. Shortness of breath, you certainly have to circle that one. If somebody's got chest pain, does pneumonia cause chest pain? And a lot of patients, they'll say, when I take a deep breath, it's right here. Yeah, you got to circle it. Chest wall trauma, that's a given. Circle it. Assessment of occult disease. Yeah, you got to circle it. That's why you get a follow-up chest x-ray after pneumonia. And then do we use a chest x-ray as a screen for lung cancer? No. So don't circle number 6. Our screen for lung cancer is a what? Low-dose CT. So I would circle 1 through 5. And then here you go. Osteoporosis is a possible side effect of inhaled steroids, right? It is. What other side effects may be seen with chronic steroid use? Well, I don't really know if you know this, but I'm just going to tell it to you to put it in your memory bank. When you're exposed to steroids, whether they're oral, injectable, or inhaled, over time, it increases or accelerates cataract formation, right? So maybe you don't have a cataract until you're 75, but if you're on inhaled steroids, it might be 60 or 65. So it does accelerate formation of senile cataract. So circle number 1. All right, I'm going to go through this exam checklist with you. I have one for you at the end of each section, but I'm not going through them with you except this one. I'm going to show you how to do this exam checklist. On the left side, I have some lung conditions. On the right side, I have what you need to know about them. So let me show you. The first one on the left side is acute bronchitis. What I need to make sure you know before you go into this exam is that for acute bronchitis, you know the clinical presentation. For acute bronchitis, you know how to diagnose it. Do you get a chest x-ray? No. How do you diagnose it? Clinical presentation. For acute bronchitis, what's in your differential? Might be pneumonia. For acute bronchitis, what drugs do we give? Really none. Non-form management? Passage of time. Go give them something to do. I'm just kidding. Acute bronchitis. Do you need follow-up care? Like after you diagnose it, do you need to say, come back in a week? You don't need to follow up. It's a viral infection. Let it run its course. For acute bronchitis, look at your next bullet. Recognize the normal course. For example, suppose a patient you diagnosed with acute bronchitis comes in and tells you, Amelie, you diagnosed me with acute bronchitis 2 weeks ago. I'm still coughing. Is that a normal course or a complication? Normal course. You got to be able to recognize that. And then finally, for acute bronchitis, recognize complications. Suppose a patient came in to see you, you diagnosed them with acute bronchitis. They call you 3 days later and they say, Amelie, I'm running fever. Normal course, possible complication, right? So you need to be able to do that for every one of these. The next one is pertussis. Go through the right-hand list. You got it? Pneumonia. Go through the right-hand list. TB. Go through the right-hand list. If you can do that, you will sail through any pulmonary questions on your exam, and you're going to do darn well in your clinical practice as well.